Patricia was the first to stimulate bilaterally this patient. So I entered the office and I saw a patient, a normal patient, walking normally. And I said, he's on levodopa. She said, no levodopa. Oh, so you injected apomorphine. She said, no, absolutely no drug. She said, try. So I stopped the stimulators, and within a few seconds, 2-3 seconds, he returned to severe Parkinsonism, unable to walk, and totally akinetic. I switched back on the stimulators, and immediately normal. All my professional life can be abstract with this patient suddenly cured from Parkinsonism.
Welcome to Stimulating Brains.
Hello and welcome back to Stimulating Brains, to the fourth episode today with one of the truly big heroes in modern day deep brain stimulation, Pierre Pollak from Geneva. I'm really grateful that Paul Crack introduced me to Pierre and he agreed to be interviewed in this show. And I think there are quite a few things we could learn from the conversation I had with Pierre. One may be that it's not always just about the ideas, but also about making ideas happen. And the second thing is in an allegory to a quote from Konrad Lorenz, who said, it may be more beneficial to study one animal for 1,000 hours than to study 1,000 animals for 1 hour. So I think Pierre made a great contribution by studying patients meticulously and days and nights in Grenoble, the first deep brain stimulation patients, and explored the whole parameter space of which stimulation parameters are the best for these patients. And I think that was a big, if not the part of the success of transforming deep brain stimulation from an acute effect in the OR to a chronic treatment option for movement disorders patients. So tune in and lean back. My name is Andreas Horn and our guest today is Pierre Pollak from Geneva. So thank you so much, Pierre, for agreeing to take part in this. And usually to break the ice, I try to ask a first question about the non-scientific part of people's lives. And about your life, I think it's pretty obvious because both Paul Crack and Günther Deutschel told me you're a fantastic piano player. And I heard after you retired, you have taken piano a bit more seriously, even more than before. So can you tell us a bit about that? But also, if you want, about your private life or your hobbies or whatever that you did apart from working in our field.
So when I was a teenager, I had a complete academic formation in piano and in music. I got the first prize of piano and chamber music and all the part, harmony, contrepoint. I had to choose when I was 18 between music career or a medical career. And as you know, I chose the medical career because I had many friends who were far better pianists than myself. And they did not succeed. Perhaps there are thousands of excellent pianists and musicians, and you know only 50 names.
Sure.
It's very difficult, and most of them are teachers in conservatories. So I have no regret at all. I never abandoned playing piano, but it was only 1 hour on Sunday. So I was not a good pianist during my professional career. I retired by the end of 2015. Mm-hmm. And I decided to totally stop neuroscience, which was incredible. They told me, you will be unable to stop neuroscience.
Sure, yeah.
So I decided, and I think I succeeded. It was very difficult for the first year, but I succeeded. And my first hobby is piano and music. So chamber music with friends. I have friends in the Orchestre de la Suisse Romande, OSR. It's an excellent orchestra from Geneva. Mm-hmm. And we play music, chamber music with them. It's a very great pleasure. But as I'm a little lazy, I don't work a lot, my piano. So I need challenges. And there are competitions for amateurs. And the first one and the most famous one was created in Paris. And I participated to this competition. Its name is Competition for Outstanding Piano Amateurs. Okay. So I didn't succeed to get to the finals, but only the quarterfinal.
Oh wow, that's amazing!
I was in the first 10 out of 100 pianists, but every 2 years. There will be a new competition, but it's not a real competition. The name is competition, but it's only for music lovers. It's a non-competition competition. Yeah. And I will continue because I made a great progress, and I think that I resumed my teenager level now. So
oh, that's good. Great. Do you have a recording that we could even put on the website, or that to people to hear you play? Would that
not during the competition, but in my home? Yes, I have recordings. So that's
love to hear that.
That's possible. That I have to hear to these recordings to know if they are correct or not. I can send you one. That's possible.
Great.
I have a second passion. It's sport. So now from my retirement, I am in far better shape than when I worked.
That's great. That sounds like a good decision you made.
So I made a lot of cycling with all the great Alps passes, and like the Tour de France competition, and also all winter sports, alpine skiing, Nordic skiing, skating, and hiking also with skis.
Amazing.
I live in such a beautiful region. There are all the mountains. Chamonix is only half an hour from my home, very close to Geneva.
Nice. So it seems like you made the correct decision to stop science to do such amazing things like sport and music. But was there a particular reason that you said, I have enough?
When during my professional life, I think I worked too much. And I remember every weekend I said, I would be so happy to work my piano and to go cycling. So now I can accomplish all my passions, and I keep only an intellectual interest in neuroscience. So I read some basic articles in Nature or Science, but I totally gave up reading neurology or even movement disorders.
Makes sense to me. Totally understandable. So, but in your career, which had like amazing moments, who were defining role models and why, or what were the turning points? Who stuck out? Who influenced your thinking when you started?
I would quote two neurologists. The first one is Yves Agide. Mm-hmm. I don't know if you know Agide from Paris, La Salpêtrière. By the end of my neurologic education, I spent 6 months in Paris, and I was interne in France. It's called interne. When you are educated in your specialty, with Yves Agide and François L'Hermite And Yves Agide was really a mentor for me. He taught me all the basic rule of neuropharmacology. At that time, I was involved in pharmacology. I remember my first study was with Yves Agide on domperidone to demonstrate that domperidone could improve the effect of dopamine agonist because it will stop side effects like nausea. So you can easily increase the dose of dopamine agonist without side effects. The same as levodopa with peripheral decarboxylase inhibitors, because domperidone doesn't enter the blood barrier. It was my first paper published in the Lancet.
Oh, wow. Good start. Yeah, amazing.
And Yves Agide told me all the scientific approach of research. Was really my mentor, and he insisted always on the pathophysiology of all symptoms you can see. If you don't well understand how the brain works, if you don't have a basic study, so even a clinician should be involved in animal studies, in basic research, to better understand what he see on patients. And to improve and to make research is very important to have a view on basic research and clinical application. So Yves Agide. And my second mentor was my Grenoble neurology head, was Jean Perret.
Okay.
And Jean Perret was very important for me for not only because he taught me general neurology, but mostly how to behave with patients. And this is very important. The way you approach a symptom and you understand the symptom, and the way you explain to the patient what you understand and what you want to do and to share with himself the treatment you propose. And also he taught me how to manage a department. He was head of the neurology, the Grenoble neurology department. He has been head for perhaps 20 years. And I was his successor in Grenoble. I was head of the neurology department in Grenoble and after in Geneva. And I think that what Jean Perret taught me was very important for my complete career. And you know, when you are a physician, you added many other duties. First, you are a clinician, and after, if you have an academic career, you make research and teaching, and after, it's administration. It's very important. When you will be older than 50, you will see.
Okay.
This is very important because nobody
teaches you that.
How to manage a group of in Geneva. I think I had 45 neurologists in the department.
It's a lot, yeah.
And you know, when you have a lot of physicians and a lot of people, you have a lot of conflicts. So it's very important to deal with them.
In the interview with Paul Crack, you also mentioned that you were among the first, or it was new at your time before you became head, that you could focus only on movement disorders.
Yes.
Right? So that specialization, and then that enabled you to see a lot of patients, of course.
But thanks to Perret.
Okay.
Because Perret, even in the 70s or 80s, 1980, he understood that to make good neurology, you should focus on one part of neurology. And he let me develop movement disorders. And in Grenoble, we create a movement disorder clinic. And it was the first movement disorder clinic in France.
Okay, yeah.
Before Paris.
Oh, wow.
So, and we have some beds dedicated only to movement disorders, and a group of physicians, nurses, psychologists, physiologists dedicated to movement disorders. And it was very important for the quality of the neurology we delivered to patients.
Makes sense. That is so normal today, but it's good to hear that it developed at some point. So makes a lot of sense. And maybe now let's dive into the main topic of today a bit. So you were potentially the leading or one leading figure of really introducing deep brain stimulation to movement disorders and to introduce the modern day DBS, basically. And Paul Crack told me that you were behind really systematically analyzing all the effects in a meticulous way and spending like days and nights with patients. That's what he said. And of course, together with Alim Louis Benabid, I think you made history with the first deep brain stimulation success stories of our time. So how did it emerge? How did the concept emerge?
I should pay tribute to Benabid, very beginning of deep brain stimulation, because Benabid was, I think, the only neurosurgeon in France in the 70s to perform the classical thalamotomy. Perhaps there was 5 cases a year about this. It was very rare. After the introduction of levodopa in the 70s, surgery almost disappeared. So Benabid continued, and there was excellent indication in severe tremor, Parkinson patients, or patients with other type of tremor, with a severe essential tremor, for example, or some patients with a tremor related to multiple sclerosis. Because Benabid is very curious. In one patient, was a patient with a MS tremor. You know, before lesioning, before performing the lesion, all neurosurgeons use the stimulation.
Yeah.
The aim of this stimulation was to be sure that you do not induce adverse effects, sure, such as paresthesias, motor contraction, which means that you are too close to the pyramidal tract, or speech suspensions, speech arrest. It was very important in the target was the VIM thalamotomy. As you know, the tradition was to stimulate using 50 hertz, and Benabid used 100 hertz, and many frequencies and 100 hertz. And what he saw in an awake patient, the tremor was totally abolished. So first, he thought that it was a motor contraction because the patient was a severe tremor. Stimulation at 50 hertz, severe tremor. At 100 hertz, no tremor. So it was a motor contraction, and we asked the patient move, because I was in the OR. It was one specialty in the Grenoble surgery, and I think Benabid was very open-minded with this, to have a medical neurologist in the OR. The tremor stopped without contraction, and the patient was able to move. And it was absolutely synchronous with the stimulation, with perhaps 1 or 2 second delay. So this was the very first discovery. And the second one is to transform an acute effect in a chronic effect. So Benabid introduced a connecting lead from the definitive lead. He said, the patient, now you go to the neurology department, and Pierre will try to reproduce what we see in the OR, because it was not sure that this was...
was that with an external stimulator, or...?
Yes, it was an external stimulation through a connecting lead in the parietal area. There was a connecting lead. And the first patient was externally stimulated for 3 weeks, and we was afraid of the risk of infection.
Sure.
Of the duration of this external stimulation. And we stimulated the patient. So after all the work was done in neurology. So the initial idea and demonstration was done by Benabid. And after, all the determination of the electrical parameters, how it worked, was done in neurology, in the neurology department. And we use a stimulator which was not permitted in humans.
Okay.
And this was because Benabid was the head of the research department, the INSERM research department. He made a lot of basic studies in rats, in monkeys, and in rats we used stimulator. I remember the WPY stimulator, and it was possible to stimulate using all the range of frequency from 1 hertz to 10,000 hertz, all the with pulse possible. I don't know if I can say this, but on this stimulator, it was written for animal use only.
Okay. Wow.
But it was a stimulator.
Sure. And in the Lancet 1991 paper that you then published, you could really see that you tested all these frequencies, right? In I think 4 patients at the time, you tested 50 hertz, no effect. Then you see like a U curve, right? And then up to very high frequencies, you still see effects. So that showed that at the time, I think, as I understand it now, these stimulation parameters were not at all standardized, right? This was terra incognita, and you tested all that.
So I was involved in this study. I was alone with the patient, with the very first patient, and I spent hours thanks to patients. Really, there was patience.
Yeah.
And,
patient.
For them, they were so spectacular. All these first patients had tremor, or tremor-dominant Parkinsonism, or mostly essential tremor and some MS tremor. It was so spectacular for patients that most agreed without difficulty to try to find the best electrical parameters. So I tried to maintain constant some parameters and to move one, and after to have a balance between all electrical parameters. And what I saw in the very first patient is that the frequency is crucial. Nothing below 30 or 50 hertz. Nothing.
Yeah.
The benefit began at 50 hertz and plateaued at 100 or 100. And for tremor, some patients had an increased benefit from 100 to 200. But generally, it was 100, the plateau.
Yeah.
And after I studied the pulse width, and it was clear that the narrower pulse width was the better.
Yeah.
And the voltage, it was only the anatomical diffusion of the current. So the benefit to risk ratio, benefit to adverse effects ratio was according to the anatomical location of the electrode. So it was possible increasing electrical intensity or voltage to know exactly where was the electrode according to the sensitive path, to the motor part, to the pyramidal tract, and other tracts involved in some symptoms in the thalamic region. So I work with the trials and errors with patients, and I think that this has not been done for other indications.
True.
It has been done after for STN, but it was done for VIM after STN, and that's all. Now there are more than 20 indications, not all validated. I think that it's a crucial point.
So I couldn't agree more. And one thing I think that is missing in this story is that most stimulators, especially in the US, were not allowed to go above 50 hertz because apparently there had been some epileptic seizures in surgeries. So that is maybe why, or it could be that this was not discovered earlier, because as you say, everything below 50 hertz.
It has been discovered by other neurophysiologists. I remember a paper by Denise Albefessard, who was a neurophysiologist in Hôpital Foch in the Paris region. And the neurosurgeon was Gérard Guyot. He made a lot of thalamotomy. And she was also involved in basic research. So she used the same type of stimulators with all available frequencies. And she wrote the beautiful paper that if you use 200 hertz, you stop tremor in patients. That's many years before Benabid.
Okay.
So the idea of Benabid, the second idea, because the first idea had already been discovered by other neurophysiologists. So I think that his main idea was to transform an acute effect discovered only in the OR, and those had not the idea that it could be therapeutic because there was physiologists, there was not clinician. And Benabid had the idea to the possibility, if the effect was permanent for weeks with the external stimulation, it would be possible to implant stimulators, because before movement disorders subspecialty, Benabid was involved in pain, and he operated many patients with pain surgery with implanted stimulators. So he knew that it was possible to have chronic stimulation. So in this very first patient, as in neurology, we demonstrated that the acute effect seen in the OR was maintained over 2 weeks, 2 or 3 weeks. We decided, with the approval of the patients, of course, there was no ethical committee at that time, but of course everything was done with the approval of well-informed patients. And we decided to implant it, the stimulator, and the first stimulator was exactly the same that was used in pain surgery.
Amazing. And that was pain for the spinal cord stimulation, or
spinal cord, but also in the thalamus, but more posteriorly.
Makes sense. Yeah. Wow.
And that's why the utmost frequency available in this mitral 1 stimulator was 130 hertz.
And that stuck, right? That's what I heard. Yeah. So
if it was 100 hertz, the classical parameters would have been 100. It would be 150. It would be 150 hertz.
So that
upper limit was 130 hertz.
Amazing. That and it's still used today. So that is
the narrowest pulse width was 60 microseconds. So that's why the parameters, because of the pain stimulator first used in the patients.
Which stimulator was that?
Mitral, ITREL 1. Mitral 1.
Medtronic is
Medtronic,
right?
yes, it was Medtronic.
Wow. And that brings me to a related question. You know, I think in our field, technology has always shaped what we can do and what is possible, and what also has shaped what concepts can be tested. So I think this anecdote is the best example for that, or one of the best examples. Do you see other things where technology shaped the way we did deep brain simulations in your time or even now?
The precision of the targeting was crucial.
True.
That I was very confident, because I think that Benabid is really an excellent neurosurgeon. He controlled everything, and we knew with less than 1 millimeter precision the 3D where the electrode was. That's why what we saw in the OR was reproduced after, because the permanent electrode was introduced exactly in the same place. So, and because he used ventriculography at that time with a superimposition, and it was such a precision.
Amazing.
So I was sure when the patients entered the neurology department, I was sure that it was possible to reproduce exactly what we saw in the OR.
So the way I picture it is somehow you sitting with the patient, testing with the externalized amplifier, and you already know this is possible. We can stop tremor with the push of a button. How was the feeling then? Because that was real new world, right? So how did it feel like?
I have not a memory of a great discovery, but only of a small improvement, that it was possible to replace a permanent lesion by permanent stimulation with the advantage of adjustment, so we can control the adverse effects. There was adverse effects. As you know, I tested all the electrical parameters, so when increased voltage, of course, created adverse effects. And what was very important also is to have in our brain the anatomy of the region, the precise anatomy, to understand what occurred in patients and to know what we can expect as side effects. Not only paresthesias, of course, it was more too posterior, motor contraction, too lateral, speech arrest. It's not well known where it is, but there was a lot of adverse effects, and what we expected is to have first tremor arrest And after, when we increase voltage, the appearance of adverse effects. So, but it was exactly according to the precision of the targeting. If the target is exactly in the 10, so you will first have tremor suppression without side effects. But if we increase, of course, there's a volume. That's why I made a parallel between voltage and anatomical spreading of current.
Then after VIM DBS, you started or you moved on to subthalamic nucleus DBS. And I think that may have started because of Haggai Bergman's paper that, before, as far as I understood it, people were afraid of the subthalamic nucleus because of hemiballism. And then in the MPTP monkey, it was shown that stimulation of the SDN can be helpful for Parkinson's. And then you, again, like the Grenoble team, as far as I know, were also the first to test this. And I heard that Patricia Limousin might have been the person to switch on the bilateral SDN. I would love to talk with her as well later in the show, but can you maybe share some memories of that time? Paul Crack said she came into the room and says, patient can walk again. And that, of course, and then first nobody believed it, but apparently bilateral STN was another breakthrough done in Grenoble.
Yes, it was really the breakthrough. I remember very well, I can tell you the story. I was in an outpatient clinic in my office, and suddenly Patricia busted into my office. I was not accustomed with this behavior because she's personality is a little bit shy, and she didn't say hello to the patients and Pierre, come. I thought that as the head of the neurology department that there was somebody dead and there was a emergency, something. And I was in the other office, and there was the first patient bilaterally stimulated in the STN. In this patient, it was patient number 3. All the 3 first patients was operated unilaterally because we expected that unilateral STN could be sufficient to improve Parkinsonism, but this was not true because our very first patients had severe akinesia and rigidity, very severe. And I remember this first bilaterally operated patient told me, after the first unilateral STN stimulation, it's good, your operation. Before I was tetraplegic. Now I'm hemiplegic. So in these severe patients, we decided to bilaterally operate. Patricia was the first to stimulate bilaterally these patients. So I entered the office and I saw a normal patient, walking normally. And I said, he's on levodopa. She said, no levodopa. So you injected apomorphine. She said, no, absolutely no drug. She said, try. So I stopped the stimulators, and within a few seconds, 2-3 seconds, he returned to severe Parkinsonism, unable to walk, and totally akinetic. I switched back on the stimulators, and immediately normal. All my professional life can be abstract with this patient suddenly cured from Parkinsonism.
That must have felt amazing. And I hear that these very first patients, they were followed for a very long time, and all the stories are there, and one could even write a book about the single cases somehow, because at the time, Paul Crack said every patient was an experiment.
In STN, we did exactly the same work as for tremor patient at the VIM thalamus. And we demonstrated that the frequency was important, but with slightly less higher frequencies. 100 was sufficient generally. But in tremor patients, some patients were better with the higher frequencies, not in the STN. And we used also, it was the ITRL2 stimulator. Also, the first stimulator made by Medtronic dedicated to movement disorder patients was perhaps 10 years after the beginning of DBS in movement disorders. The first stimulators were only developed for pain.
But that one still had 130 hertz limit, or the itral one?
Itral 2 also, 130. And for tremor, we asked to increase the possibility, and Medtronic developed stimulator with the upper limit at 185, but useless in STN generally. But the narrowest pulse was also 60 microseconds, and they didn't develop 30. We asked because we demonstrated that 30, 40 was very effective, and it was not available in the very first simulator.
That's amazing, because I think that really was introduced just a few years ago by Boston Scientific and also Medtronic with the flashed heart rate. So I still remember, but you had shown it back in the 80s. So
if you study very well the patients, if you know this patient perfectly for years, you know all these symptoms, and you reproduce this many times, the reproducibility is very important. So if you work in a scientific manner with reproducibility, and you are sure you need only one patient, n equal 1, to demonstrate that it works.
Sure.
A patient is like this, stimulators on, no tremor. You don't need a lot of patients. Sure. If it doesn't work in other patients, we have to understand why, the reason. But if you mastered all the condition of the anatomy, the physiology, you can reproduce.
I sometimes think of the same way about even other, diseases like depression or so. If you have one patient where Helen Mayberg said actually in the same podcast that, if a battery depletion of a depression patient happens and the patient comes into the emergency unit, because, that is more or less proof, because the patient couldn't know it. It can't be placebo, but the stimulator turned off and you have one patient where it worked. So you played a major part in this development, but of course you were a team. So how was the interdisciplinary collaboration in Grenoble like? What was the relationship maybe with Alim Louis Benabid, and also who were other important figures? We've talked about or mentioned already Paul Crack and Patricia Limousin. Can you talk a bit about that?
I think that the team approach was the major reason for the success of the Grenoble team. Benabid, he launched ideas. Every minute a new idea. Is incredibly intelligent and creative. But after, all is the ideas for the neurologist. So we have to pick some ideas and to transform these ideas in scientific medical facts. The second quality of Benabid is as a neurosurgeon. He is really an excellent neurosurgeon, and all the electrode was perfectly inserted. After the neurosurgeon, I think that the neurophysiologist in the OR also was important, was Benabid, has also some competence in neurophysiology, and Hamid Benazouz was also very important in the OR only. And also important because he was responsible for the rat studies. Because before the first human implanted in the STN was many rats and monkeys. And Hamid Benazouz was the neurophysiologist involved in this basic research, very important for the translation between from animals to humans and for the success in humans. In the neurological team, there was many neurologists, because after the success of DBS in tremor treatment, I had many fellows from all the world. And I was very lucky with this. And all these fellows were incredible, good and intelligent neurologists. For tremor, there was Claire-Lise Gervason. She did not make an academic career after. And after Claire-Lise, Patricia Limousin, really the most important collaborator. And now, she's a professor of neurology at Queen Square. Paul Crack was a fellow he has been for 1 year, and after he came back to Grenoble, and many. Elena Moreau from Milano, and there was many from Spain and from really all countries, even from the States. So I had a great chance because all these demonstration of effects were time consuming. And if I was alone with tremor patients, in STN patient, we operated the second or the third year, the 50 patients a year. So it was very, very important to have a big database. And more importantly, neurosurgeons, neurophysiologists in the OR, basic neurophysiologists, neurologists. It was important to have a neuropsychologist because ethically I was afraid to stimulate the brain chronically. So many possible adverse effects. So from the very first patients, I asked the neuropsychologist Claire Hardouin to deeply study all the cognitive, the emotional, and the behavioral aspect of all patients. So she spent also hours with patients to know them before surgery and after surgery, because we're afraid that it could be some personality changes. So the psychologist and Claire Hardouin, I think that without Claire Hardouin, it would not be such a great success. And the control, the mastering of all the effect of DBS and the correct management of patients. And the other parts of the team were neurophysiologists. It was important, especially in dystonia, in GPI targets, and also in STN and severely akinetic patients. And all the team of movement disorders, the nurses, we had at that time nurses specialized in Parkinson's disease. Because as I told you, with my second mentor, Jean Perret, we let me the opportunity to develop this movement disorder unit. So the team approach was mandatory for the success of the team.
If we see this in retrospect now from a modern day, I think the common perception is that in Grenoble you started something like modern day deep brain stimulation. But the concept of course, brain stimulation is much older and may even date back to Robert Heath or Jose Delgado in the 50s in the US. So were these early pioneers an inspiration to the Grenoble team, or was it a completely new rediscovery, or what was crucially different?
We have already spoken of this. I mentioned Denise Albefessard. Of course, there was many papers.
True.
And some American neurosurgeons stimulated everything in the brain. But all these studies were uncontrolled. There was in the short term, and it was done more in a physiological aim than a therapeutical aim. So the spirit was different. So it's exactly what we discussed. The merit of our team was to transform an acute physiological effect in the OR in a therapeutical effect.
Makes sense, yeah. That became clear to me. That the transformation to make this permanent, or this effect permanent. That is so. Maybe before we wrap up, beyond what we already talked about, and the breakthroughs we've already mentioned, would you have a particular story of maybe academic or clinical success or surprise that you would like to share?
There was many, but I think that Paul Crack mentioned you this story of a patient, and we tried to increase voltage, and he began to laugh and to have a lot of ideas. And at that time, I understood, in the STN, there are the three compartments, the motor, the associative, and the limbic part. And we can, according to the placement, the location of the tip of the electrode and the voltage, so according to the volume of stimulated tissue, we can influence each part of this STN. And this was also reversible. It was incredible. When it was stimulated with a voltage slightly higher than was necessary to improve akinesia, he began to make jokes and to laugh and to have a lot of ideas and to be very vivid, and it was incredible and reversible on demand according to the voltage.
Would you think that the SDN could be a depression target?
Yes, I'm sure. Yeah. I'm sure. An excellence.
I think so too, personally, but it hasn't been explored much, I think.
We should know exactly where are the electrodes for mood. The Swiss, he works in
Schlepfer?
Oh, yes, Schlepfer. Yes, he stimulated in the VTA or something, but
might be the SDN.
I wonder it was not. Yes, yeah, it was very, very close.
Yeah, it's true. It's very close. You can't rule out. That's true. So, since we talked about successes a lot, would you also be able to share a story where things went wrong, or it just didn't work out as planned, or you thought this was a complete waste of my time?
Yes, I was afraid of the possibility of loss of benefit, because in some tremor patients, it was in the 80s, 88, I knew patients who progressively lost the benefit on tremor. So I increased voltage, new benefit. And after a couple of weeks, tremor recurred. I increased voltage. And I remember in one patient, I increased up to 8 volt. And what occurred, it was the addiction process, the rebound effect when we decreased. And it was not possible in this patient to stop stimulation. So I was afraid that this could occur in many patients. And in fact, it occurred in few patients. And I think perhaps because the location of the electrode was not exactly where it could be. It's a supposition. I'm not sure of the reason why. And Marwan Harris described patients arriving in the emergency ward with this rebound, and extraordinary tremor. And of course, in the STN, it could have been the rebound of severe akinesia, more severe than the basic akinesia. Of course, this did not occur. But I was really frightened by this possibility of loss of effect. And it's a mystery why this did not occur, because there is the physiology of the brain and the Cannon process for all the vegetative system showed us that the body accustomed to everything, but not the brain to stimulation. Is incredibly lucky for this. The logic would be a progressive loss of benefit.
And in the BIM, we have that, of course, as well today, that if you turn it off, you have a rebound effect. But I can only imagine. So nowadays, we just know that, and then we know that after 2 days or so, or a day, it's better. But you didn't know that, right? Because you were the first. So I can only imagine how frightening this could have been.
So don't increase voltage too high. Don't be modest with the electrical parameters. It's like for drugs, not use too high doses.
So to wrap up, based on your vast experience, how do you perceive the field of neuromodulation today? What can we learn from the early days for the future? And what should a young generation of today know or maybe not forget from the earlier days?
My concern is that most groups trying to demonstrate that DBS could be effective in other locations in the brain and other indication, other diseases, based their studies on the electrical parameters discovered for tremor and akinesia. And all this basic research we did is not reproduced now with new targets. And for example, we thought that the mechanism of high frequency stimulation was to jam the message and to avoid a wrong message. So an inhibitory effect, a global inhibitory effect. Of course, it's stimulation, but globally it mimics inhibition. But not in all targets. In the PPN, low frequency was better than high frequency, 10, 20 hertz, for example. So my concern is to stimulate the brain in the right way. It's to stimulate using a significant electrical message. And this is not for tomorrow. It will be very difficult to mimic the normal brain functioning because the neuronal discharges are so complicated that to mimic a normal message would be very, very difficult. But I think it could be the future to inject a significant signal. So with a closed loop stimulation in the STN is the beginning of what I'm saying. It's to understand what is the wrong electrophysiology and to stimulate exactly when this wrong electrophysiology occurs. But it's too simple. So for the future, it's really the injection of normal neurophysiology, because high frequency stimulation is very silly. It's only to avoid the wrong message and
somehow even have to inject information, and that needs to be meaningful. So it might not even be enough what you're saying to inject physiologically mimicked signals, but probably the brain even needs something meaningful. So I think there's a long way to go. But
yes,
yeah.
I would say one point to add, which is not discussed generally in the paper. It's the D of deep brain stimulation. Why deep? Why does it work when it is deep and it doesn't work well when it is cortical or superficial? And this is true with many targets and new indications. I think because as far as we know on the functioning of the brain networks, all the brain networks are anatomically like a funnel. So the deeper you are, the greater network you can impact. An effect even on a small part, and the stimulation is only expected to influence 2-3 millimeters, about a small sphere, 2 or 3 millimeters in diameter. That's all. And if you influence such a small part, if you want to have an effect on a complete network, you should be deep. And I think that's why all the trials on cortical stimulation and now on TMS are not very effective. They have some effect, but not great effects. And if you introduce an electrode in the brain, there is a risk, 2-3% hemorrhage infection. And to justify such a great risk, huge risk in comparison with pharmacology, it's incredible. You should have a great benefits, great beneficial effects. That's why I think the anatomy, the anatomy of the brain, pathophysiology should be the basic reasoning of all neurologists, and always based on basic research.
Great. So the SDNs to me sometimes seems to be a miniature of the whole frontal cortex, because it receives input of the whole frontal cortex. So that is, I think, what you're referring to, right? By stimulating a small part, you can have an impact of a large network, and that is hard to do on the cortex. You would need a very large electrode or something. Yeah.
Yes. And many parts, because of the network everywhere in the brain, and all parts of the brain are useful.
You're right. Okay, thank you so much once more for participating. This was a great honor, and I think you really could give us a beautiful insight into the early days and the magic in that time in Grenoble. And I couldn't thank you more.
It was my pleasure, and I'm sorry for my poor English and some problem, because I think now it's almost 5 years I have not discussed about the brain and DBS.
Wow, 5 years.
I would discuss about music, far better than neurology. So sorry because I had to search my words, and I'm sorry for this.
I think you were amazingly into it. So maybe you can consider coming back to the field. We would be glad to welcome you.
Thank you.
Thank you so much.